we've long had the dilemma in clinical practice about which of our early stage hormone receptor positive, HER2 negative early breast cancer patients benefit from an anthracycline, the chemotherapy agent called doxorubicin. We have three main chemotherapy agents that we use to help increase the cure rate for early breast cancer patients, our hormone receptor positive, HER2 negative patients, and that is the doxorubicin, the cyclophosphamide, and one of the taxanes, either docetaxel or paclitaxel. And the question is, which of the patients need all three drugs and which of the patients just need two drugs? And the two-drug regimen that we use is called TC, which is docetaxel and cyclophosphamide. And we really haven't had any kind of really good, strong data that we can use in practice to make a determination. And it's important because the doxorubicin does bring in additional toxicity. When you give three chemo drugs as opposed to two, you're going to get more toxicity. And also the doxorubicin has a very small long-term risk of leukemia and heart failure. So very small, but again, any is too much. So we really would like to only use the doxorubicin in patients who are really going to benefit from it. But and just to back up and say one more thing, and that the first decision to make when you've got a patient newly diagnosed with early breast cancer that's hormone receptor positive, HER2 negative, the first question is she going to benefit from chemotherapy at all? Or is she not, in which case she can be treated with endocrine therapy, anti-estrogen therapy, and one of the new CDK4/6 inhibitors. And we've been using MammaPrint for a long time, as well as the Oncotype recurrence score, to make that decision about who's going to benefit from chemo versus not. So we have good tools for that decision on the MammaPrint or on the Oncotype recurrence score. Then we're going to recommend chemotherapy, but the question is, what chemotherapy? Is it going to be the two-drug regimen for just 4 cycles, docetaxel, cyclophosphamide, or do we recommend basically 8 cycles of ACT, 4 of AC, followed by 4 of a taxane, with the A being doxorubicin? So it's a lot longer therapy, it's more therapy, it's 3 drugs, and it has more side effects. So who really needs the anthracycline? And we've not had any good tools to really help us distinguish that. And so that was the point of the study that we've been working on, and that we presented the data at San Antonio. I have been doing this nationwide real-world evidence trial called the FLEX trial. Investigators across the country. I'm the principal investigator on the trial. And what it is women with early breast cancer of any subtype. Most of them are hormone receptor positive, HER2 negative, but it can be any subtype. And these are patients where the physician believes it is in the patient's best interest for the physician to order MammaPrint along with BluePrint. BluePrint is a very quantitative way of doing breast cancer subtyping. What kind of breast cancer is it? Is it lower risk, endocrine therapy sensitive, ER positive breast cancer? That's luminal A. Luminal B is more highly proliferative, less endocrine therapy sensitive, higher risk, ER positive breast cancer. HER2 enriched is when the breast cancer is actually driven by the HER2 oncogene. And then basal is really when the breast cancer has the biology of a triple negative breast cancer. So we have been ordering this as standard of care for a long time in order to understand which patients benefit from chemotherapy or not. And so if the patient has MammaPrint and BluePrint ordered as per standard of care by their physician, then they sign a consent and we collect all of their data, all of the tumor data, all of the patient information, what exactly they're treated with. And then we follow them for 10 years for their outcome and make sure we know along the way what treatments they're actually taking and making sure they remain cancer-free, or if they recur, when do they recur, what sites of disease, what metastasis do they develop. But all of this information about their tumor and about them is collected in this nationwide registry. And the goal is at least 30,000 women will be enrolled, and we're well above 20,000. It may be closer to 25,000. By now, it's a very, very large study. And it's, as I said, we were going to collect the data for 10 years on every woman. So one of the things that was very important in the trial that we presented at San Antonio, the subset analysis from the FLEX trial, is that though the FLEX trial is not randomized, it's a real world evidence registry prospective trial where data are collected prospectively, but the patients are not randomized to TC versus ACT. And so there could be imbalances in the two arms with regard to prognostic features around the cancer, or different important factors like age, for example. So there is a very well established statistical methodology to analyze real world evidence to basically account for differences in prognostic variables between the two groups you are comparing in your real world evidence analysis, and that's called propensity score matching. So it's to even out and adjust for imbalances in important prognostic factors between the TC and the ACT treated groups in the high risk 1 population separately from the high risk 2 population. And the variables that we adjusted for in the propensity score matching analysis between the TC and the ACT groups were age. We matched the patients by age, by tumor size, and by nodal status, node negative and node positive. And we basically have cohorts within the high 1 group and within the high 2 group. We've matched the TC and the ACT patients to choose patients in both groups that are matched based on age, tumor size, and nodal status. And so that really does smooth out the imbalances in the group and kind of really gets rid of the imbalances that we can control for here. There can still be other imbalances that we're not controlling for, such as other comorbidities, for example, but we've controlled for the main things we can control for here. And so that's what gives this analysis much more validity, is the fact that this propensity score matching has been done. And what we still see is the TC patients and the ACT patients are doing the same, then they're doing very well in the high risk 1 group, but in the high 2 group, it really is the patients who received the ACT, the addition of the anthracycline, who really benefited, and the TC patients were doing much worse, basically at that 3-year mark with already an 11% chance of recurrence. So that's what I think really made the this analysis strong and led to the NCCN incorporating it into its guidelines. This affords us a lot of good opportunity to find out, okay, let's take the women who are estrogen receptor positive and HER2 negative, early breast cancer. They've had their MammaPrint and their BluePrint. Let's take the patients who are high risk by MammaPrint. And let's take the patients who on BluePrint are the Luminal B, the more aggressive of the estrogen receptor positive, HER2 negative breast cancers. Let's take a look at that group of patients. And then let's look at the women who got TC chemotherapy, the lighter chemotherapy. And let's look at the women who got the ACT, the heavier chemotherapy that includes the doxorubicin. And then let's see what their outcome is in terms of, did they recur from their breast cancer or not recur from their breast cancer? But then furthermore, let's break it down, the high risk group, into 2 buckets, high risk 1 and high risk 2. And high risk 1 is the lower 50%-ish of the risk. They're high risk women, but they're at the lower end of the high risk. And then high 2 is approximately the upper 50 percentile, the ultra high risk, that have the highest risk of recurrence. And let's see if they got treated with the TC versus the ACT, how they did. And did it make a difference? And what we found out was that for the high risk 1 patients, so again, ER positive, HER2 negative, early breast cancer patients, high risk on MammaPrint, and Luminal B on BluePrint, which again is high risk, but estrogen receptor driven, okay? And for the high risk patients, it didn't make any difference whether they got TC or ACT. They were sitting at about a 95% of remaining free of recurrence at just over 3 years median follow-up. Now, very important caveat here. This is not a prospective randomized trial. These patients were not randomized to TC versus ACT. The physician and patient made the decision together about which chemotherapy to give them. And in general, the patients who got ACT are higher risk patients than those who got TC, generally lower risk in terms of just their clinical pathologic features. But in the high 1 category, so all high risk, but the lower end of the high risk on MammaPrint, they were doing very well. They all got anti-estrogen therapy called endocrine therapy, and 95% of them had not had a recurrence at that 3-year mark, regardless of which chemotherapy they received. Conversely, in the very high risk patients, the high 2 patients, there, if they got the ACT, where the doxorubicin were added to the TC, then they really did very well. At the 3-year mark, there was they had not had any recurrences. 100% of the patients had remained recurrence free. Whereas if they got the TC, they did worse. 11% of those patients had a recurrence. So only 89% remained recurrence free. So this really tells us that it's the high 2 population, the high risk 2, the ultra high risk population that really is benefiting from the ACT, from the addition of that anthracycline, that doxorubicin to the TC. So this can be very useful to us in practice because we can be sure, number one, most importantly, I think, that the highest risk patients do get that doxorubicin to improve their outcome, because they don't do nearly as well if they don't get the doxorubicin. But also importantly, that for the high risk 1 patients, really, they may not need that doxorubicin. Now, I will say my personal opinion is that before we back away from all high risk 1 patients that before we back away from doxorubicin and all the high risk 1 patients, that I think it has to be individualized with the patient. I think it depends on how high their risk is, their anatomic risk, the grade of their disease, the key 67 of their disease. I think we have to look at the big picture, because but the high risk 1 patient, I'm not prepared to say that all patients should not get doxorubicin high risk 1. We're going to do a very important validation trial for these data based on a randomized clinical trial where patients were randomized to the TC versus ACT. And then if it really turns out the high risk patients absolutely don't benefit from the doxorubicin, then I will be comfortable saying, really, we shouldn't be using it for that population. But right now, personally, I think we need to individualize for those patients. So great news. The NCCN, our National Guideline Committee in the United States, that basically sets the standard of care across the U.S. and sets insurance coverage across the U.S. very recently, in the last couple of weeks, has decided that these data that we've been accumulating, and this is not the only trial, but we've been accumulating, have really shown that the high risk 2 patients benefit from the doxorubicin, the high risk 1 do not, and therefore that they endorse the use of MammaPrint and BluePrint to use patients, for physicians to use to help get the best information, to then counsel the patient and make recommendations about whether they should get doxorubicin or not, in the group, of course, who need chemotherapy in the first place and are ER positive and HER2 negative. So that's very, very good. So for the first time, we really have a tool that's endorsed by the NCCN to help gather this information and then use this in the decision-making with the patient about whether they should get TC or ACT.